Next, we're going to move on to step 3, which is ask. And the first slide in ask is, of course, what you would expect, which is we're going to talk about trauma-informed care. It is extremely important when we are interviewing a potential victim that we are coming at this from a trauma-informed approach. And trauma-informed approach will recognize the impact of the past and the present abuses in how a person presents in a healthcare setting. And this is going to be recognized holistically in their behavior, their health, and their body language. I like to refer to trauma-informed care as an understanding. It requires us to understand not only what trauma is, but how trauma is impacting the individual from a perspective of their triggers. How are they going to be re-traumatized in the medical setting that they happen to be in? And how can we provide an understanding of trauma to the victims? Because what I found in my work is that not only do medical professionals not necessarily understand how the trauma is impacting the victim, but the victim themselves doesn't understand how the trauma is impacting them. And then helping victims to not only to understand that trauma, but to manage feelings and find some semblance of control in the situation that you're in. As much control as you can allow them to have in the setting is a great thing for giving them that feeling of empowerment, and it will help with you in the relationship moving forward. And then supporting their emotional safety, not only emotional safety, but of course as well their physical safety. It's really critical that that particular victim feels safe in the experience that they're having with you in the hospital or whatever medical setting they're in. So why is it important? It's important that we develop a trauma-informed approach that is both supportive and considers the holistic impact, because we are attempting to create what I like to refer to as a transformational relationship with this particular survivor or victim of trafficking. A good friend of mine who also does trafficking outreach, her name is Sandy Scalani, and she does a great TED Talk, and it's about the transformational relationship. And what that is saying is that we are going to create a relationship with this victim or survivor that they have not experienced before, because we are going to allow them to feel empowered, we are going to allow them to feel supported, we are going to understand where they're coming from, and we are going to allow them to feel safe. And we're not only going to do that in the half an hour that we spend with them in this first appointment, but we are going to create that in an enduring way, in a long-term way with that survivor. That is what a transformational relationship is, and that's what will help that survivor or victim to understand that they have other options. That is what's going to do it. So it's really important that if you've never had any trauma-informed care training, that you go out and get some and experience what it is like to truly develop a transformational relationship with the person that you're working with. So what to do? Let's say that you now have an understanding that somebody within the setting is indicating or is coming across to you as a victim of trafficking. So before you continue, one of the most important things you can do is to separate that patient from anyone that is accompanying them, regardless of what they say the relationship with the person is. As we described earlier, 36% of DMST victims are actually being trafficked by their immediate family. So if a girl or a boy is being trafficked by somebody who indicates as their mother, or if a woman is being trafficked by someone who indicates as their husband, that really may be the actual relationship they have, but that doesn't mean they are not being trafficked. And it's really important that you understand that you will be unable to obtain the relevant information if the trafficker is with or near the patient. The patient is not going to answer you honestly while the trafficker is there. In addition, If the patient does not speak the local language, it is crucial to make sure that an interpreter is available once you remove them from their own interpreter, who is also possibly their trafficker. There's a variety of reasons that can be used for the separation process, such as it's a hospital or clinical protocol. There is a need for lab work or urinalysis, or the patient has to go for an x-ray or another scan. This is something that you'll want to develop as you start to establish procedures within your medical community for how to address identifying a trafficking victim. Next, have someone establish the level of, this could be done with a medical social worker or case manager, as they are generally trained in developing trust and working through a process with a client. If they're unavailable, a nurse or another staff member may be able to assist. It is ideal that this person be the same gender as the patient and have an understanding of the principles of trauma-informed care. It is very key to build rapport and trust with this patient. As I was saying earlier, it is that trusting relationship that is really going to help meet the individual's immediate needs. And you may want to look at what are the immediate physical and emotional needs of the client, including potentially food or snack. Maybe they need something to eat or something to drink. Consider what ways you can really build a relationship with this person. And if the healthcare professional strongly suspects trafficking, it may be helpful to have the victim return to the clinic or hospital for a follow-up visit. This will allow for a reevaluation of a healthcare issue and for further assessment and questioning that may lead a patient to disclose more information about their situation. Next, we'll talk about the process of separation. Okay. So once you have officially separated a victim, you may, what you're going to want to do next is ask them some additional questions. So there are several tools out there in the community right now that exist that provide us with questions that may help to identify trafficking victims. One such tool is called the Trafficking Victim Identification Tool, which is by the Vera Institute of Justice. And this particular tool was actually validated within victim services communities, and the short version has 16 questions and the long version has 30 questions. And the feedback that I've received is that may be too many questions for a medical setting, but I think it's important that you have a tool like this in place that you can use to determine what questions are good to be asking to these victims. Obviously, the number one question not to ask is, are you a trafficking victim? Because you've already determined that they're going to probably not identify as a trafficking victim. So it's about getting the verbiage down that you need to use in order to ask the right questions. And of course, this will assist you with many things, including making the appropriate referrals and gathering your facts, as well as identifying whether there was force, fraud, or coercion, and also standardizing your screening procedures. So here is a couple of potential screening questions that you could ask. This will give you an idea of the types of questions you would see from a tool like the Vera tool. And as you can see, we're not asking, are you involved in trafficking? We're asking questions like, have you been injured where you work? Were you ever stopped from getting medical care? And have you ever not received payment for the work that you've been doing in the U.S.? So those are the types of questions that we need to be asking.
So this is Kim. Kim again. Thanks, Elizabeth. So screening does work. Colleagues of mine and myself recently published a original research article in an FQHC clinic-based setting, which showed that providers can be pivotal players in identifying victims of commercial sexual exploitation. We had 621 patients from 2008 to 2011. Of those patients, we looked at high-risk indicators and screened 177 of them. 13 or 7.3% of those patients who were screened confirmed they willingly, when they were asked, disclosed that they were being commercially sexually exploited. So this article is available. It's free online, but you don't have to use the questions that we used. What's most important is that you ask the questions and that you understand that human trafficking does happen and can be identified in the medical setting or the healthcare provider setting. So we've looked at the 3 steps of the SOAR model so far: stop, observe, ask. And the 4th module is to respond. Now this is probably one of the most important parts. What are we going to do after we ask the questions and we have identified people who are being trafficked? This next section looks at the next steps to be taken once you've identified a victim. So once you've identified a potential victim, there are some practical steps for what should happen next. We already talked about separating the patient from anyone who is accompanying them, getting an interpreter, interviewing the patient, getting a proper history, building trust with the patient, all the things that a healthcare professional normally does in the course of seeing patients. So we'll take a look at the specifics for gathering more information, reporting as required, making referrals, and utilizing additional resources.
Okay, so we're going to talk a little bit more about separation as it relates to establishing a protocol or procedure within your medical community. Of course, we discussed how important it is to separate them, but we should establish ahead of time who will carry out the actual separation process and what will occur if the person accompanying the patient refuses to leave their side. Strict criteria should be set for when and when not to intervene once a patient has been separated. If a decision is made to proceed with an intervention, a clear procedure must be determined in advance that includes notification of internal and external security officials. Informed consent will need to be obtained from an adult victim, and local child protective services will need to be contacted for a minor. Remember that victims may not understand the term human trafficking and may be reluctant to leave their trafficker at their side. That's what we were talking about earlier in regards to how the trafficker may have gained control, coercive control over the victim. So this is where it's going to become very real. The fact that human trafficking is a criminal activity means there is an inherent danger involved with any type of intervention. Most of the danger centers on the patient who has now been identified as a victim of human trafficking by the healthcare system. If an intervention is planned and fails, the victim may suffer additional abuse and trauma from their trafficker. In addition, the staff of the hospital or clinic may be exposed to some level of danger. So it is critical to work through the safety component of any intervention before it is carried out, using input from local and federal law enforcement and hospital security. So when you are interviewing this potential victim, the patient may exhibit certain red flags, but more information is often needed to determine that they are actually someone who is being trafficked. When interviewing a potential victim, there are some things to keep in mind. As stated previously, make sure that the patient is separated from the person accompanying them and that they are in a safe location before asking any screening questions. It should be established early on who in the healthcare facility will be doing the interview, and interviewers should make sure to use empowering language and reassure the patient that they did not do anything wrong. Ask the patient for their own interpretation of what has happened and what they would like to do next. Your ideas may or may not be in line with their desires. And this is where it becomes very critical that we practice trauma-informed care, because we need to allow the victim to be in control of the situation whenever it is possible for us to do so. This is going to help us establish that relationship that is so necessary at this point. If an interpreter is involved, you may also want to assess whether they understand how to use trauma-informed care techniques and are able to maintain emotional control during the interview. That's really important. These interpreters may be hearing things that they are not used to hearing. They've never heard anything like this before. So it is really important that you've identified somebody who can handle what they may be hearing and interpret it literally as it is being said. And also a good note, if the patient's very uncommon language or dialect, the communities may be small and tight, and it is possible that the interpreters may know the victim or the traffickers. So it's important to ensure there is no conflict of interest in the situation, and to try to understand that ahead of time if you can, if it is a small community. In addition to standard hospital or clinical protocols, a screening tool can be used to gather more specific information. Information obtained with this tool may be also helpful for your partners in the legal and social services communities as well. And make sure to minimize the number of interactions the patient has with healthcare personnel. It can be extremely re-traumatizing for a patient to be constantly telling their stories over and over and over again. And if they have to tell it within the medical community multiple times, and then they also have to tell it to law enforcement, and they have to tell it to social workers, it can just be extremely draining, and can lead the victim to really not want to discuss it anymore. So so do try to limit that as well if you can. And here we're going to see a case study that's done that talks or shows a specific case of labor trafficking to give you an idea of how you could respond within your own medical community if you spot this type of activity.
They say some people cut themselves with dull knives. Well, I tend to believe that we're more careful with sharper knives. The good news is, your cut isn't deep enough to warrant surgery, but I will have to put in stitches just to make sure your wound heals properly. What kind of knife did you cut yourself with? Yo no habla inglés. She doesn't speak English, so. Okay, hold on. Let me get you an interpreter. You don't need an interpreter. I was there. I can tell you exactly what happened. Okay. Why is the cut on her hand so deep? Watching what she was doing, obviously. We really need to get home. Do you know how long this is going to take? I really need to get an interpreter, and I really need to know what happened from it. My husband's boss is coming for dinner tonight, and that man really likes her pineapple salsa, so she was doing the pineapple, and the knife slipped and cut pineapple. I mean, you know how easy it is to do that. Yeah, I can imagine, but I really need to get that interpreter. Give me 1 second. This is Dr. Jackson in room 1. I need a Spanish interpreter in room 1. I need you to step outside. I need to speak with Anna alone. Hey, I'm the one paying the bill. That gives me every right to stand right here beside her. We just want to get Anna taken care of. That's the most important thing, but I really need to get home. Tonight is very, I understand. It won't take long at all. We really need to get home. Is there any way to keep this up? You can also holler and have a cup of coffee, and as soon as we're done, I'll come and get you. Okay, I'll be quiet, all right? But I'm just going to stand right up there, okay? It's going to be right there. No, ma'am. The waiting area will be more comfortable. Fine. Is your best friend interpreter? Hi, Sarah. How are you? Oh, I'm fine. How are you doing? This is Anna. I really need your help with asking her about questions. Okay. Okay. Yo soy Sara, mi interpretante. Yo voy a ayudar al doctor. Ella quiere hacerle unas preguntas acerca de su mano. How did you cut your hand, Anna? ¿Usted cómo cortó su mano, Ana? Yo cortaba la fruta was cutting fruit. Were you in a hurry? Your cut is deep. Usted estaba apurada porque su cortada se ve bien honda. I noticed your bruises and burns. Where did you get these? He notado unas quemadas y unas moretes. ¿Dónde recibió eso? Me quedé en la estufa y los cortes corrientes no han caído en el baño. I got the burns from the stove, and the bruises are from my fall in the bath. These do not look like normal bruises from a fall. How long have you stayed with Ms. Thomas? Estos no parecen moretes normales de una caída. ¿Cuánto tiempo tiene usted trabajando para la señora Tomás? 5 años. 5 years? Do you like living with Ms. Thomas? ¿Le gusta a usted trabajar por la señora Tomás? Mira, trabajo en un lugar para estudiar en la casa. She gives me a job and a place to live in her home. Are you able to leave, Anna? ¿Usted tiene derecho de irse de la casa? No. Señora, no. Mrs. Thomas does not like me to leave the house. Anna, I'm really concerned about your work situation. It seems to me that you're not able to make your own choices. And I'm really worried about your injuries. If you want, we both can call a hotline to seek you some free help. Ana, me preocupo por su situación. Parece que usted no tiene los propios derechos de salir o ir. No tiene usted ayuda. Parece que están maltratándola. Nosotros podemos ayudarle a llamar un número donde ellos le ofrecen ayuda. Estoy bien, no quieres ayudar. No, I'm fine. I don't need any help. I'm fine. Okay, I'm sorry, I entiendo. Well, I've made you a follow-up appointment to come back and see me so you can get your stitches taken out. On the back of the card is a number where you can call just in case you wanted to seek help. Yo le hice una cita a usted para venir la próxima vez para que le saquen las puntadas del mano. También atrás está un número de una ayuda. Si usted desea ayuda, se llama. Okay, there's my coffee. So, are we done? I'll have my nurse get your hand up. Sarah, could you take Anna to room 3, please? Yes, ma'am. Vamos, le voy a llevar a cuarto 3 para que le saquen las puntadas. ¿Está bien? I've made her a follow-up appointment to come back and see me so I can remove her stitches to make sure her wound is healed properly.
Oh, thank you. That won't be necessary. We'll just take her to get the stitches removed at another clinic. Thank you very much, really.
Does Anna live with you? Does she travel with you?
I probably really shouldn't be.
No. Anna will be fine. Does she live with you?
Yes, she lives with me. I have 3 children. She gives me help. Is there anything else? Do I need to pay you money or what?
You can pay at the front desk, but I would really like for you to reconsider making sure Anna comes back to get her stitches removed.
Fine. Thank you.
Thank you.
So that was a video, a demonstrated case of a labor trafficking example in an examination room, and you can see that there was a lot of red flags, there were a lot of suspicious signs and physical indicators, and so those are the things that you should be looking out for in your examination room. After you are suspicious of or identify a patient who is a victim of human trafficking, you want to be aware of the reporting statutes in your state or your county. And mandatory reporting requirements dictate reporting, then you have to report. State requirements vary. You have to work within existing guidelines, and you should be documenting the medical record in a way that supports the patient as a victim. For example, you should not be documenting things like for a child who is being commercially sexually exploited, you should not be documenting things like involved in prostitution, because again, we know that any commercial sex act of a minor is defined as human trafficking. There is no such thing as child prostitution, period. So mandatory requirements vary from state to state and within states, or where tribal law has jurisdiction. So you should find out while you're making your protocols and deciding how to approach this topic area for your patients, to know what the requirements are in your area, and continue to work with the HIPAA guidelines, or the Health Insurance Portability and Accountability Act. State laws on suspected child abuse, domestic violence, and vulnerable populations abuse may apply even if you're not sure this is a trafficking case. And in many states are now defining commercial sexual exploitation of the child as child abuse in their statutes. So that is something for you to be on the lookout for in your state. So, and again, while it's crucial to document well, it can at times be used against a victim of trafficking, so there should be guidelines in place for what and how best to document in your medical record or your electronic health records. I talked a little HIPAA, or working with the Health Insurance Portability and Accountability Act. Sometimes when we do these trainings, healthcare professionals are wary of reporting because they're fearful of violating HIPAA rules. But you should remember that HIPAA was written to protect patient confidentiality. It was never designed to prevent the reporting of trauma and crimes. First and foremost, our patients' safety is paramount. We don't have enough time to go into specific scenarios on when not to report for this training, but ultimately this will be the healthcare professional's decision. You have to take into account your responsibility as a mandated reporter and obligations to protect patient privacy. However, in making these decisions, you have to understand that the HIPAA privacy rule permits reporting of injury or abuse provided certain conditions are met. Even where specific permission to report injury or abuse does not apply, if an adult patient authorizes a particular disclosure of information, HIPAA requires only that the disclosure be limited to the terms of the authorization. Finally, if you're unsure about whether HIPAA permits the reporting of patient information in a specific situation, human trafficking can still be reported without divulging individually identifiable patient health information. For example, a healthcare professional could report the gender, age of patient, and type of trafficking. So we've seen that healthcare professionals play a major role in identifying victims of human trafficking. However, utilizing the larger referral network is necessary to provide the services needed to protect the victim, help them recover, and prevent further trafficking. If you think you've encountered a victim of human trafficking, it's important to collaborate and coordinate around key service providers, including local law enforcement, social service providers such as shelters, food banks, and others mentioned on this slide. This helps to ensure that victims receive the help and services that they need. The local law enforcement and social service providers may also give you some information about the types of trafficking occurring in your area. This can help when compiling a list of red flags and indicators specific to your local population. For example, local vice officers may be aware of common street names and tattoos used by traffickers working in your area and the specific types of trafficking present. And I want to bring it back to the federally qualified health centers. So FQHCs are really key at integrating physical and behavioral health within the community health center. So, and that's one of the benefits of a federally qualified health center, as is the use of enabling services at the federally qualified health centers with patient navigators, case managers, social workers, interpreters, eligibility counselors. So there may also be at your health center a medical legal partnership. So again, the FQHCs are ideal places where we can care for victims of human trafficking, identify them, prevent it, as well as provide long-term care. The steps we've just covered are components of a human trafficking protocol. In order for this protocol to be successful, you do need to find a champion within your health center or your health setting who can work effectively with the senior management. You need a whole team to be able to effectively identify and care for these patients, because it's not solely a medical issue. This needs to be a person, the champion, who has the authority to move the process forward within your healthcare system. When you develop a protocol, consider reaching out to the local stakeholders and victim advocates to assist in the development of a healthy and safe protocol. So it doesn't matter whether your facility is a hospital, clinic, or a standalone practice. Identifying the champion and empowering them to develop a protocol is critical to helping victims of human trafficking. All right, so in protocol development, protocols for interacting with victims of human trafficking, it could be developed by adapting and using current systems or protocols that respond to victims of domestic violence or child abuse. At my health center at Asian Health Services in Oakland, California, that's exactly what we did. We based our screening protocol and our questions and what we did after someone was identified. We based it off of our domestic violence protocol for patients. So the components of a human trafficking protocol within the healthcare system should include many of the things we've just talked about, such as a list of red flags based on the local trends in trafficking, a separate, maybe to your policy that patients should be separated, should be interviewed alone, and the medical history obtained alone and with a separate interpreter who's not a family member or someone accompanying the patient to the healthcare visit. Third, interview procedures. Once the patient is separated and ready to be interviewed, the protocol should address the following. Who's the designated interviewer, and is an interpreter needed? How is trauma-informed care techniques going to be utilized during the interview? What translators will be used and how to contact them? The specific questions to be asked and the order to ask them, and also how to incorporate a screening tool if you desire to use that in your setting, and the appropriate procedure if the patient is confirmed as a victim of trafficking. Safety planning is essential. Safety for the victim, the medical staff, needs to be considered as well with the intervention. You should prepare in advance for certain scenarios and consider these, such as what happens if the trafficker refuses to be separated from the patient, or what will you do if you are pretty certain or suspicious that the patient is a victim of trafficking, but the patient refuses any intervention. So you should think about these things in advance with your team so that you can have resources in place or ways to reach the victim. Fifth, mandatory reporting. Again, going back to the previous slide, what are the state and local requirements on this? And sixth, the referral network. You must partner with local, state, and tribal law enforcement and social service providers, such as shelters, nonprofit organizations, and legal service providers in your area. The federal law enforcement may need to be involved as well, or other federal agencies, depending on the case. If it's a foreign national victim, you might need to get immigration involved as well. Engaging with other stakeholders allows for the strong support of the victim and the provision of necessary resources.
This is Rochelle. So we wanted to show you an example, and just one example of a protocol in practice. This morning, our colleagues in the Department of Homeland Security released a video that we're going to show you right now, and it's geared toward healthcare professionals. Afterwards, we'll come back and talk about it.
Dale, niña, apúrate. La boca cerrada, que yo soy la que voy a hablar. Dale. Is there something I can help you with? Yes. My niece is sick. I don't know what's wrong with her. Wait right here. Go with that. And I'll get someone to take a look at her right away. Thank you. Tú no le dices nada a nadie, o ellos van a llegar a la cárcel bien lejos de tus padres. ¿Tú me entiendes?
Hi, I'm Anna Mitchell. Is this young lady who's not feeling well?
Yes. She doesn't speak English. I'll translate for her.
That's okay, I speak Spanish. Tell you what, let me take her back to the examination room and find out what the problem is.
Okay, let's go.
Oh, I'm sorry. Patients only. It's clinic policy.
But she'll be scared.
Cariño, no te preocupes. Estarás segura conmigo. She'll be fine. Siéntese aquí, por favor. ¿Cómo te llamas?
Pablita.
Ok, Pablita. Voy a checar tu corazón y respiración. ¿Está bien? Respira profunda. Muy bien. Otra vez. Pablita, es un nombre muy bonito. ¿De dónde eres?
Honduras.
Honduras. Es muy lejos, ¿no? Is that your mother with you?
No. No. Yo trabajo para ella.
¿Qué tipo de trabajo haces?
Cosechamos tabaco.
¿Cosechas de tabaco? Es trabajo muy difícil para una niña.
Sí, pero tengo que hacer.
¿Por qué? Wait with her, I'll be right back. Todo estará bien.
So as you see on this video, you're going to see facts being shown and phone numbers coming up from our colleagues at the Blue campaign at Homeland Security. Like I said, this is brand new. You're one of the first audiences to see it. The website, if you want to go to it directly, is www.dhs.gov/blue-campaign. It's really interesting that coming out today as we do our historic first webinar with you. And I want to bring this back to the fact of the Federal Strategic Action Plan. We're working side by side with law enforcement on creating these kind of tools for the healthcare professionals. And what I saw in that video immediately was the receptionist and her reaction to the young lady, and then also not being able to get past that front door because the doctor's saying clinic policy. Those are issues around that can go into a protocol development. You may have seen other things as well. But we like what we saw there. We like the fact that that trafficker got stopped, basically. So as I mentioned, we have all of these different parts of the federal government working on human trafficking. Blue Campaign is part of the Homeland Security effort. We're going to learn from each other, and we're going to improve things for different audiences, whether they be health centers or hospitals. As a former HRSA employee, I love the Access Agency and I love the community health centers. And I think that there's definitely a role going forward and in the past for health centers to be the first responders, and especially in this, the 50th year of health centers. I want to now talk a little bit about the federal resources. You see the different agencies involved. Within HHS, the Administration for Children and Families is taking the lead on human trafficking. One of the things we did first was set up a hotline. So that's the National Human Trafficking Resource Center. Phone number there, 888-373-7888, and of course the website. You can see information about the grants that we have. I tell you, this is an exciting time because up until 2014, we did not have many grant programs for domestic trafficking, federal at the federal level. This year we started having grantees focused on domestic human trafficking, and we're going to have even more of that. So we hope that you've gotten in this training that labor is important and sex is important in terms of trafficking. We want to always talk about both because you never know which you're going to see coming in to the health center or the hospital. The Blue campaign is the third bullet. They're the ones that produced that new video that you just saw, and there's that website I mentioned. The Office of Victims of Crime, also in Department of Justice, and then we work closely with Department of Labor as well. We have stakeholder meetings. They help us with our health activities, and so it really is a team effort at the federal level. This is the slide for the Resource Center. I told you the phone number. You can also, it's a 24-hour hotline, and there are other hotlines then. I need to say that there are survivor-led hotlines that are very important, and many of these, maybe all of them, feed up to the National Human Trafficking Resource Center. Anywhere in the country, a call can be made. It's not necessarily that you see a case, but you might want some information. You might want to just give a tip, and you can go on that website and you can get information about human trafficking. They also do trainings as well. So we have, you can see that this field is changing. This field is improving. We have emerging national partners. And APCHO is definitely an emerging partner. They have a cooperative agreement with a part of HHS, Health Resources Services Administration, and they're going to be providing trainings and technical assistance resources on human trafficking for the FQHCs. We know that the other partners will step up to the plate as well, and we appreciate APCHO for their leadership in working in partnership with us. Another national partner that is emerging is the healthcare field itself. You know, we heard Dr. Chang give a wonderful presentation side by side here with Elizabeth and I. This is an organization that is emerging. It's relatively new. It's independent, interdisciplinary network of health professionals working to combat human trafficking. So as feds, we're going to be turning and working with the HEAL Trafficking Network and others to help develop, for example, HIPAA case studies. We need to give you tools so that you have examples of what to do when you're seeing a potential case. So there's a website for the HEAL Trafficking Network. So we wanted to just review our learning objectives. We hope that we have described sufficiently the scope and diversity and types of human trafficking, and that you'll remember force, fraud, and coercion for the rest of your life. Yeah. We hope that you recognize the common indicators and the high-risk factors, and so that you can really see what you are seeing, not just in a healthcare setting, but just in everyday life, because human trafficking is all around us. It's outside the grocery store. It's on the metro. It's everywhere. So unfortunately, our numbers about human trafficking leave a lot to be desired, but we're also working in that area as well. Objective number 3, we hope that you got a lot of good information about trauma-informed techniques that could build on your already existing knowledge about it. And we hope we've given you some local and some national referral resources. At the state level, we refer you to the Human Trafficking Hotline. They can refer you to other places. Also, our websites have great information. Grantees who's being paid to do trainings and provide resources to those who want to learn more. This is my contact information. I'm the project director for the SOAR trainings. We are building this as we go, and that's fun for me and our colleagues. And so we would love feedback about how did this training serve your need? This is the first time we've done it as a webinar instead of doing it live. We also want to know what more we should be doing more. We did this presentation about a month ago, and a dermatologist said, well, yes, I need to know about human trafficking. I said, we have healthcare professionals being trained. And she said, no, you're not hearing me. I'm a dermatologist. I'm a specialist. I need to know from my practice what this is going to be about. So we're coming up with adaptation guides for different populations. We also know that healthcare professionals are working with social workers. And so we're training social workers. Those trainings start in 2 weeks. Yay. So they're going to get a different type of SOAR, but it will have a lot of the same information. It's exciting to see the field move in this direction of collaboration. Thank you.
So thank you, Rochelle, thank you, Kim, and thank you, Elizabeth, for this really informative training. We're going to now begin the Q&A portion of the webinar. So as I mentioned at the beginning of the call, this is Isha, we will start by answering questions submitted to us via the chat function. If you would like to submit a question now, please do so using the questions field on your screen and indicate to whom your question is directed. So our first question is from Sabrina Matov-Stapp, and it's directed to Dr. Chang. Her question is, interpersonal violence is prevalent in many communities. From your experience working with health centers, what are essential components at the system level to integrate screening and counseling for IPV in the health centers? Are there similarities from your work with human trafficking specifically that could be applied to IPV more broadly?
Hi, Dr. Madoff-Stapp. Nice to see you on the call. Thank you for the question. So your question was around what are the similarities between interpersonal violence screening and protocols, and how can that be applied to human trafficking? Is that right, Isha? So actually, I'm glad you asked that question because they are actually quite similar in my view and from my experience. As I mentioned during the training, from my work at Asian Health Services, a community health center, a federally qualified health center in Oakland, California, we actually adapted the domestic violence, our domestic violence protocol to the commercially sexually exploited children screening. And so I think we often get into situations in academia where we put topics into silos: human trafficking, domestic violence, child abuse. Whereas my view is that none of these three vectors of violence operate alone. They're interrelated. And Elizabeth is nodding her head here. Maybe she wants to chime in. And so I think we can learn a lot from the IPV sector, and IPV can learn a lot from the human trafficking movement as well. Elizabeth wants to say something here, I think.
I know that in the hospital that I am working with, we are actually taking the protocols for IPV and adapting them to include screening for human trafficking as well as protocols for human trafficking. And it is very, very hard to separate these. I know as a family-controlled survivor, I often talk about the fact that domestic violence, sexual abuse, and sex trafficking are completely and inextricably linked within families that practice trafficking. You cannot have sex trafficking without the others. As a matter of fact, the others are often used as the kind of brainwashing and breaking of the child before the sex trafficking even begins. So it is critical that we understand the link and that we are prepared to address all of the aspects of interpersonal violence that are a part of trafficking in general.
Thank you. Again, I just want to remind you all to submit any questions in that question box, and also wanted to let you know that there will be a short survey that will be emailed to you. You'll get a link to it right after you close the webinar. So if you could answer that for us, that would be incredibly helpful for future trainings. So I have a question while we're waiting for other questions. So when we think about patients who have cultural and linguistic needs, can you suggest any best practices of how the SOAR training has been conducted within an FQHC? and have these materials or resources been disseminated?
That sounds like a question for Dr. Rollins.
So your question is about cultural competency
And best practices.
and best practices
In FQHCs.
In FQHCs.
in FQHCs. Well, we're at so much at the beginning of the cusp on this. I can't say in the terms of human trafficking what's happening. I'm sure a lot is happening in the other sectors of violence, domestic violence and sexual violence. But I don't know of examples myself. Does anyone else?
Well, you did do the SOAR pilot training in several community health centers in Oakland, in Alameda County.
Yes.
And you also did it in the Bakken region.
Yes.
And that was with community health centers as
well. Well, it was with a hospital. It was on a tribal reservation. And, well, one best practice I can say from going to North Dakota and seeing the rural population is that you need to have the services in place as well. We did an impromptu meeting with the hospital director there because we're trying to understand. We're coming here to talk about human trafficking, and you're saying that your hospital is closing, and we're looking at, and we know that in rural and frontier communities where HRSA has clinics, there's a need for the activists, the service providers who are focused on human trafficking and violence to also be advocates for just plain old services as well. So I think that mirroring the topics is a useful thing to do. In terms of a best practice, we trained dentists in Atlanta. We worked with the Greater Dental Society of Georgia, North Georgia, and one of the practices that we heard was very much separating. The X-rays do need to happen, and when we were engaged in training them, they said, "Well, yes, we definitely can separate them, and our clinic is such a low-income area that we often see strange activities, and in every single training with the healthcare professionals, without a doubt, there was a conversation of, boy, you remember that person we saw last month? And you could see the light bulbs going off. So I don't know about best practices, but the beginning of awareness was what we were aiming for, and I know we got it every place we went.
That's great. Thank you. We did get another question from Dr. Maytoft-Stepp for Kim. Given how busy FQHCs are in dealing with chronic illness management and other priority issues, what do you suggest are ways to integrate IPV or HT screening and counseling into universal protocols of care?
Mm-hmm. That's a great question, Dr. Maytoft-Stepp. So you know, my health center is in California, and I know that we do have some requirements to do domestic violence screenings at the physical exams. And I think sometimes leadership within the FQHC, at least at this point in time, is essential, and it might be going organization by organization to get that universal screening or asking about these questions or getting the trainings in the FQHCs. I mean, even if you look at it across the country, not all states have adopted the federal legislation defining a person under the age of 18 as a victim of sex trafficking if they're involved in a commercial sex act. So you know, we're still looking at that front. Legislation front at the state level, and then in different states where they might have the mirroring legislation, different counties and the different district attorneys approach it differently for domestic minor sex trafficking. So I think at this point it's almost mirroring the child abuse movement, where it's growing and organization by organization, institution by institution, adopting the leadership and taking on the topic areas and developing best practices that way. I don't know, maybe Rochelle has more insight on the federal level and how to, you know, mandate screening in FQHCs or in other institutions, hospital settings?
Well, the way you described it, it's going to take some time, and it's not the most efficient way of bringing change, of hoping to work at the federal, state level with large organizations that can make change. For example, medical societies, dental societies, heck, even at the education level, American Association of Medical Colleges, working with the nursing leaders as well. So I don't work in the legislative component of anything, but where we see opportunities, we can jump on them and have trainings ready and tailored for different populations.
Great, thank you. We have a few more questions, but I just wanted to remind you all that you will be getting a copy of the slides after this training is over. So this is a follow-up question, and I think both of you had addressed this in your previous answer, but if you have anything to add. Have any health centers shared with you the protocols that they have developed to incorporate human trafficking into daily operations and as a result of the training?
Well, so this is Kim. You know, Asian Health Services just published that journal article in April, last month actually, and that's free and downloadable online. We put our screening tool on there and how we ask the question and what we do there. We also have another article, it's in review, that will come out at some point on how we developed the screening protocol, and that will be widely and freely accessible and shared, and so that's online. Elizabeth here has something.
There's also, as we mentioned earlier, the Heal Trafficking Network is currently in the process of developing a sample protocol. Now, I don't think it will be specific to health centers, but it will be something that may be adaptable. And my understanding from the founder, co-founder of Heal Trafficking, Susie Baldwin, is that will be out over the summer and be available as well.
Okay, thank you. And that question was from Sharon Barrett. There's another question from Marianne Gervais. She asks, oftentimes we have limited time with a patient, as in the case of the video with the cut. And if the family does not bring the girl back for a stitch removal, what would be the likely next step for the clinic? Should they report to an agency of suspected abuse?
I think I'm going to jump in here first, Kim. I think one thing we maybe didn't stress enough was that rescue, and I don't like that word rescue, but that change, it's going to take some time, and that's why you want to develop that trust. So that victim may not get out of that situation the first, second, third, or even fourth time that they are in front of a healthcare provider. But like we heard in the audio, at the right time, they will say something, or the timing will be there for that person to get the services that they need.
And this is Elizabeth, and one of the reasons why I highlighted the transformational relationship when I talked about trauma-informed care is because it is through that relationship that a victim will eventually become comfortable with coming forward and telling you about their abuse or trafficking situation. And I know it's frustrating. I hear from the medical community all the time. I've got 20 minutes with this person. I know they're being trafficked. They refuse to tell me they're being trafficked. And there really isn't much else you can do. You can't become the trafficker and, handcuff them to the wall. I mean, it's just not possible for you to control them in that way. So what it really comes down to is just letting them know that you're safe, that you understand, and that you're willing to empower them in the situation, in the relationship that you're building with them, in hopes that they will come back and they will tell you, and that they will understand that they actually have an avenue to get out of their situation.
Thank you.
Yeah, this is Kim. I mean, it's very similar to domestic violence, where you may ask the question in several different appointment visits or in several different settings, and the patient may not disclose. It is a cycle of abuse, And so it often takes several iterations of asking for that disclosure to happen. And one thing at our site at Asian Health Services, what I didn't mention is that we had seen many of these patients several times before they disclosed, and we had asked many times before they had disclosed. So you know, that is a component of the physician or the healthcare professional patient relationship, building that trust.
Thank you all. Thank you all for this great Q&A and the great training. It's great to see all these experts in this room and learn a lot for the past couple hours. So if we were unable to answer your questions today, this slide includes how you can follow up with us. Please don't hesitate to contact policy@apcho.org for any additional information, questions, and/or concerns that you might have. You can also learn more about APCHO and our members on our website at www.apcho.org and about the SOAR training on ACF's website, as Rochelle had mentioned earlier. Lastly, I would like to thank Drs. Chang and Rollins and Ms. Corey for all of their work in such a crucial area and for being here today. APCHO will continue to have trainings and webinars about issues surrounding human trafficking in the months ahead. Please keep an eye out for an email from APCHO, as I mentioned earlier, that's going to include a link to a short survey. And as I mentioned earlier, you will get a link to the slides as well. Thanks again and have a great rest of your day.